Good morning. I'm Henry Wang. I'm an emergency physician. I've spent the last 20 years of my career studying pre-hospital resuscitation and care systems. So let's start with some vignettes. A 60-year-old male develops 10 out of 10 crushing chest pain while mowing the lawn. Bystanders see him in distress and call 911. Paramedics are dispatched within 1 minute. They arrive on scene within 10 minutes. They connect the patient to their 12-lead monitor, find an inferior wall myocardial infarction. Following evidence-based protocols, they give aspirin, morphine, and sublingual nitroglycerin. They transmit the 12-lead EKG to the nearest STEMI receiving center. The physician is able to verify the presence of a myocardial infarction and activates the cath lab team. The members of the cath lab team start moving in from home and mobilizing the room in anticipation of the patient. EMS arrives at the hospital within 30 minutes. The cardiology team is ready for the patient, and so therefore they bypass the emergency department and go straight to the cath lab. The cardiology interventionalist starts the case at T equals 40 minutes and finds the culprit lesion and reperfuses the patient at T equals 45 minutes. Let's consider another emergency, a 25-year-old male involved in a horrific head-on motor vehicle collision. Witnesses call 911. Fire and EMS units are dispatched. A helicopter and medevac is immediately put into the air. Medics arrive on scene at T equals 10 minutes. They find a victim unconscious, breathing but moaning. His systolic pressure is 60. His heart rate is 150. They pull him out of the car and rapidly move him to a nearby ambulance. They perform rapid sequence intubation. They have portable ultrasonography available and determine the presence of free blood in the peritoneum. They start administering packed red cells to the patient. Based upon a recent study, they now carry fresh fluorescent plasma and start administering this concurrently. Not only that, there's knowledge that TXA can be useful in hemorrhagic shock, and they also give TXA to the patient. Because of the patient's severity of injuries, the command center is able to identify the nearest available level 1 trauma center that is best able to prepare for this patient. In this case, an extra 3 minutes of flight time to go to a farther center. They activate the trauma pagers remotely. The trauma team assembles in the emergency department. They are ready when the patient arrives at T equals 30 minutes. They rapidly assess the patient, go through a CAT scanner, and they take the patient immediately to the operating room for an exploratory laparotomy. Let's go to another scenario. A 55-year-old male develops a bad headache and now realizes he cannot move the right side of his body. He is able to call 911 and tells the dispatcher, "I think I'm having a stroke." EMS dispatches an ambulance and a special stroke ambulance. They arrive on scene at T equals 10 minutes. They confirm that this patient may be having a cerebrovascular accident. They put the patient through their portable CT scanner, confirm that there's no head bleed, and proceed to give him thrombolytics. The Cincinnati Pre-Hospital Severity Stroke Scale, recently developed and validated, suggests that this may be a large vessel occlusion, and therefore they start plotting course to a comprehensive stroke center, a place more capable of doing interventions for this type of a cerebral vascular accident. They leave at the scene at T equals 30 minutes, arrive at the stroke center at T equals 40 minutes. They bypass the emergency department and go straight into the interventional lab, where they find a proximal right carotid occlusion and successfully perform a thrombectomy. And finally, let's consider this case of a 40-year-old female collapsing of a cardiac arrest while running. Bystanders find her pulseless. They start CPR and call 911. In addition to dispatching EMS, the dispatch center fires off the PulsePoint app, which alerts 3 bystanders within a block of the cardiac arrest that there's an active cardiac arrest within running distance. One of the bystanders grabs an AED near his office and runs to the scene. EMS arrives at T equals 8 minutes. They start ACLS. They initiate CPR using mechanical CPR using the Lucas device. They start intra-arrest therapeutic hypothermia using the Bennett-Schill nasal prong system. This cools the brain, base of the brain using a cooling system. A physician EMS unit arrives on scene. They realize that the patient has been in refractory VF for over 25 minutes. They decide to initiate ECMO in the field. Okay. They successfully cannulate the patient by 30 minutes. They're in the hospital within the next 10 minutes. They spend the next 3 days performing a cardiac cath, opening up an LAD occlusion, weaning her from therapeutic hypothermia. She awakens and goes home on hospital day 14. These are current examples of regionalized emergency care system. A regionalized emergency care system is a planned network of in-hospital and out-of-hospital resources designed to deliver care to patients with life-threatening illnesses. These vignettes may seem like science fiction, but in fact, each one of these interventions and systems of coordinated care exists today. The goal of a regionalized care system is to optimize outcomes. And simply put, this is achieved by getting the right patient to the right place at the right time in the right condition. Now, on the surface, a regionalized care system looks simple. Get this acutely ill patient, stabilize them, get them to the right place. But as you can imagine, there are many complexities to solving this simple jigsaw puzzle. So something as simple as drive the patient to the right center might be complicated by traffic. Now I have to consider trade-offs in each of these decisions. Do I drive 75 minutes to the nearest STEMI center, nearest PCI center, or do I bite the bullet and give thrombolytics now? There are several considerations, several ingredients needed for creating an effective regionalized emergency care system. The targeted condition must be life-threatening. It must be clearly defined, and we talked about the conundrum with shock and how it masquerades as other conditions. There needs to be effective time-critical treatment available for the patient. There needs to be a defined therapeutic window. This condition must represent a significant societal burden, and therefore we need to talk to our epidemiologist friends to determine the burden of these patients and to map out their distribution across the United States. There needs to be plausible integration with EMS. EMS systems must be present. We need to be aware of their capabilities. They must be able to be identified by EMS. Okay? There need to be plausible EMS interventions. Dr. Peirce gave a wonderful description of the current systems of shock care in Houston. Did it strike you how this simplified shock guidelines still look like instructions for putting together IKEA furniture? It is simply too complicated. We need to find ways to make this more simple. And regionalized care centers are very important because these are centers with specialty capabilities, and we need methods to triage and distribute these patients. But look at what happens in the current natural ecosystem of hospitals and specialized care systems. And look at the mismatch between the per capita density of these specialty care systems. So these are data I published in a paper many years ago describing the population density of STEMI, stroke, trauma, and pediatric critical care centers. And you can see that there's a complete mismatch between the population and the number of centers in many of these states. A quick summary on some of the barriers and the enablers. There are many challenges we are up against as we strive to develop regionalized care systems. EMS training and capabilities need to be expanded to accommodate new protocols, techniques, and technologies. How we pay for these systems is a big question. Insurance policies need to be updated to not only recognize the innovative care models, but also to support EMS's role in these systems. Practice variation exists everywhere and presents impediments to trying to unify our regional systems. Government regulations need to embrace these innovative systems and must consider curtailment of uncontrolled center growth in select communities. And siloed thinking threatens access and threatens the success of these systems. Egos we heard talked about in a prior discussion. To work as a coordinated system, we need to break down these silos and work together. Effective care systems have worked very well together. They have had hospitals, EMS systems working closely together and showing strong partnerships in trying to coordinate care. And finally, technology is also an important part. By introducing new innovations, we can enhance our ability to identify and care for these patients. And so in summary, I provide a very rapid overview of emergency regionalized care systems. These vignettes show what is currently possible. And I hope that these examples will inspire you as you're seeking new ways to innovate cardiogenic shock care. Thank you.
Dr. Wang, that was a great presentation. I don't know whether you meant it intentionally or not. The last part of your slide was a wall. We will build a wall here and we'll find funding for it for sure. Any questions? Yeah, go ahead.
I fully applaud the initiative. I still have two reluctancies or potential criticism. I mean, the first one is the fact that sometimes the patients are not so obvious. I mean, we discussed the trauma patient. It's easy to find that with a vehicle, usually you have a trauma. It's not a myocardial infarction leading to the ambulance and the problem. But with the young lady, I mean, the young lady is 30 years old on the ground, sometimes you will find that this cardiac arrest is due to several hemorrhage, due to SIH, and your facility where you will bring it to your level 1 should be also level 1 for the brain hemorrhage. Otherwise, you will be in trouble in these conditions. And the second drawback of this over-centralized system is also that with time, your level 2 and especially level 3 will not be able to carry on patients that will be self-presenting to the facility and will have cardiac shock or whatever. And then you will have not 12 hours, but you will have 3 days before this patient will be recognized as having cardiac shock or whatever. So you need also to, in this over-centralized system, to have also good ways to train the people in these remote facilities to still be able to perform basic recognition of shock and to be able to transfer. Whatever the ego is, it's also capacity at some point to recognize the disease, which is a problem.
Good. Let me highlight with cardiac arrest, some of the successes of the cardiac arrest field has been showing that, first of all, there's a great societal burden, 400,000 cases per year. There's clear case definition. When someone has no pulses, it's a cardiac arrest. Okay? And the vast majority of cardiac arrests are from cardiac etiologies. Yes, there are a few head bleeds, there are a few other things, but the vast majority are from cardiac etiologies. And so why in the cardiac arrest world, we have proposed the creation of cardiac arrest centers, and it passes this first hurdle of easy case identification. The second question about diluting the experience of secondary and tertiary centers, or I'm sorry, the level 2 and level 3 centers, is a problem we will always have to struggle with in the development of these systems. If we fully regionalize care, the specialized centers get better and better and better, and the referring centers don't have so much experience. And ironically, they'll start to miss cases that need to be referred to the higher level center. So these are all part of the system challenges.
Dr. Anderson, are you raising your hand or just, okay.
You know, excellent points and an excellent answer. The thing though is that we were touching on is that, and I mentioned this during my talk, is that, you know, we've got STEMI centers, we've got stroke centers, we've got trauma centers, we've got pediatric care centers, we got pushing for, you know, sepsis centers and cardiogenic shock centers. But, all right, Bob, the EMT, he needs to know, these hospitals are going to have these. If there's going to be a system where, when I use the merit badges, we've got 5 or 6 merit badges for the, you know, I need hospitals that got them all, or you're not, because it gets too confusing and it's impossible to separate out. And your point that I'm going to bring in somebody who's got an intracranial bleed where I think it's a cardiac problem, you're right, that's going to happen. So we need to, as a community, we need to start having these centers geographically, strategically placed that can do it all. And then everyone else, if somebody comes in there, they need to be trained on how to diagnose them. And then this transfer problem has got to go away. The delay in transfer, that's a problem we can solve and we have to solve.
Great. Thank you. Thank you, Dr. Wang. Thank you so much.